Good evening, everyone. Welcome to this month's Circulation, Arrhythmia, and Electrophysiology Cardiac Implanted Electronic Devices Advisory Board webinar. My name is Daniel Morin. I'm an electrophysiologist at the Ochsner Medical Center in New Orleans, and I'm Senior Consulting Editor for Circulation A&E. We've been doing several of these discussions over the past several months. They've all been excellent, and I'm sure that this one will be no exception. Before we start, I'd like to point out that the audience is muted, but you are encouraged to provide questions, and that's what the chat box is for on the bottom of your screen. Please do type questions to our panelists or hosts and commentators, and we will be sure to get to those as well as possible. At this time, I'd like to turn over our discussion to our hosts, Dr. Jordana Kron and Dr. Parikshit Sharma, who are some of our leaders of the CIED Advisory Board. Jordana and Parikshit, please take it away.
Thank you, Dan. Well, on behalf of Circulation, Arrhythmia, and Electrophysiology, and Dr. Paul Wang, our Editor-in-Chief, it's our distinct pleasure to welcome each and every one of you to our webinar. The title of today's webinar is The Impact of Leadless Pacemakers on Tricuspid Valve Function. I am Parikshit Sharma, Associate Professor and Section Chief for Cardiac Electrophysiology at Rush University in Chicago, Illinois. And my co-host tonight is my friend and colleague, Dr. Jordana Kron, who is an electrophysiologist and now a professor at VCU in Richmond, Virginia.
Thank you, Parikshit. So we're very excited for our excellent selection of panelists tonight, and the speakers are going to share with you some of their exciting research on this very important topic. As Dr. Morin said, we want to encourage you to ask questions, so please feel free to participate in the chat function. There will be time after each speaker and also at the end with our panel to ask questions. I have the pleasure of introducing our first speaker, Dr. Jojo Hai, who joins us today from Hong Kong. She's a clinical assistant professor in the cardiology division at Queen Mary Hospital at University of Hong Kong. She received her medical degree from the University of Hong Kong and did her training in cardiac electrophysiology at the Mayo Clinic in Rochester, Minnesota. She's subspecialized in arrhythmia management with a particular interest in complex ablations and device management. We're just delighted to have you here with us today, Dr. Hai.
Thank you very much for your introduction, and thank you very much for inviting me for to the seminar. And it's my pleasure to share with you. One of my study which has been published recently. So today our topic is on the impact of leadless pacemaker on tricuspid valve function. And let's just begin with some background information. So it's known that a significant tricuspid regurgitation occurs in about 20 to 40% of patients who had transvenous ventricular pacing lead. It is usually defined as at least moderate tricuspid regurgitation. And when we compare it with the usual population, it usually occurs in only about 12% of the population. So in a retrospective study, including 239 patients on ICD and 48 patients on pacemaker, significant lead-induced tricuspid regurgitation occurs in 38% of patients at 1 to 1.5 years after device implantation.
Dr. Hai, I'm sorry to interrupt you. You're doing a fantastic job to start. But what we're seeing here is the presenter view.
Sorry. It's let me try again. Okay,
much better. Perfect.
Great. Sorry. So it's in a retrospective study including 239 patients on ICD and 48 patients on pacemaker. Significant lead-induced tricuspid regurgitation occurs in 38% of patients as 1 to 1.5 years after device implantation. Significant lead-induced tricuspid regurgitation is associated with higher mortality as well as more heart failure events. In multivariate analysis, significant lead-induced tricuspid regurgitation was an independent risk factors for all-cause mortality with an adjusted hazard ratio of 1.75. So in another longitudinal cohort study, the prevalence of significant tricuspid regurgitation, defined as at least moderate to severe tricuspid regurgitation, occurs at a higher prevalence in those who had pacemaker implanted, with an adjusted odds ratio after propensity score matching being 2.6. The overall survival would actually worse in patients who has significant tricuspid regurgitation, regardless of pacemaker implanted or not. So here is the anatomy of tricuspid valve. Let us have a closer look and try to understand why it can happen in patients who have the pacemaker implantation or device implantation. So the tricuspid valve is a very large valve. It's actually the largest valve in the heart and is designed to cope with low pressure differences. It has 4 components: the leaflets, the annulus, the chordae, as well as the papillary muscles. It typically has 3 leaflets, the anterior, posterior, as well as the septal leaflets, but 2 leaflets and 4 leaflets occurred in a healthy population as well. The anterior papillary muscle is the largest, and it provides support to the anterior and posterior leaflets. And the posterior papillary muscles, which is often bifid, provides caudal support to posterior and septal leaflets. The septal papillary muscles, which may be small, multiple, or even absent in 20% of the normal patients. The chordae may arise directly from the septum to the anterior and septal leaflets. Compared with the normal mitral valve chordae, normal tricuspid valve chordae comprised fairly strict collagen bundles that are less extensible, and therefore the tricuspid valve is more susceptible to marked tethering with right ventricular dilatation, as well as displacement of the papillary muscles. So here are some proposed mechanisms of lead-induced tricuspid regurgitation. First, during lead insertions, we may induce valvular leaflet perforations or laceration. And also the chordae may be entrapped by the tied leads. And if we retain the lead across the tricuspid valve, it can also interfere with normal valvular leaflet coaptation. And the lead can also lead to entanglement with the chordae tendon. And after a period of time, it can also lead to inflammations, fibrosis, and encapsulation, which hamper the mobility of the valvular leaflet. And of course, it can also be complicated by endocarditis and thrombosis, which can further impede the function of the valve. And ventricular pacing has also been proposed to be one of the possible mechanisms. Instead of right ventricular desynchrony, in fact, left ventricular desynchrony is more supported to be one of the mechanisms. It's because left ventricular desynchrony can increase left ventricular filling pressure, and it further increases pulmonary arterial pressure, which leads to right ventricular dilatation and functional tricuspid regurgitation. So it appears that the ventricular lead itself is evil. That's one of the reasons for the development of the leadless pacemaker system. Theoretically, without the need of pacing lead, the patient will be free from pacing lead-related complications such as tricuspid regurgitation. However, in reality, it may not be the case. So in this study, which was published 2 years ago, 53 patients receiving leadless pacemaker were included, of whom 28 had nano-stim and 25 had micro implanted. It's actually found that tricuspid regurgitation worsens in 43% of them at 12-month follow-up. The findings of this study set off alarms. Alarm bells among many cardiac interventionists, as right ventricular septum is the preferred size for leadless pacemaker implantation in many centers, as to reduce cardiac perforation. So here comes to our study. We actually wanted to investigate the incidence and possible mechanism of tricuspid regurgitations following septal implantation of leadless pacemaker. So consecutive patients who had micra implanted in our center were included in a prospective registry. The study period was from 2015 to 2019. And the primary outcome in this study was worsening of TL for more than 1 grade. So consecutive patients who had micra implanted successfully at the right ventricular septum were included. As clinical and echocardiographic data were recorded at baseline. Echocardiogram was repeated for this study using the Vivid's E95 machine. So as a background, in our center, all micro devices were preferentially implanted at the right ventricular septum using a technique described by our group before. In brief, the cardiac silhouette in the right anterior oblique field was divided evenly by 2 perpendicular lines into the apex, mid-LV, and the LV outflow and LV inflow tract. The mid-LV was further divided from top to bottom into 4 equal quadrants. During implantation of a leadless pacemaker device, we first position the device as the second and the third quadrant, corresponding to the mid-right ventricular septum. In addition, the device was directed to the left, in the left anterior oblique field, and towards the observer in the left lateral field. In addition, we monitor the limb needs of ECG during the pacing to ensure a narrow QRS complex and the absence of notch. Only if satisfactory sensing and pacing parameters were not obtained was the leadless pacemaker device be positioned at the apical septum. We understand that this method is based mainly on fluoroscopy and ECG findings, and therefore its success is dependent on patient anatomy. However, performing implantations procedure in a systematic way maximizes the success rate and minimizing the complications associated with mid-septal leadless pacing. So this slide summarizes the echocardiographic assessment we performed for this study. So here are the TL assessment in this study, which was mainly adopted from updated guidelines from the College of Echocardiography. And the degree of TL was principally determined based on the ratio of color flow jets to the right atrial area in the apical 4-chamber view, and also the vena contractor diameter in the in this close-up picture. And this was supplemented by information from continuous wave Doppler, right atrial size, right ventricular size, tricuspid inflow, hepatic vein systolic flow, and inferior vena cava diameter. Accordingly, the degree of TL was categorized as none, trivial or mild, moderate or severe. So we want to also to study the possible mechanisms of leadless pacing related tricuspid regurgitation. Therefore, we measure the distance from the proximal end of the leadless pacemaker and annulus as shown in the figure on the left. We also want to study the impact of the synchrony on TL worsening. So we performed 2D spectral tracking echocardiogram to evaluate the effect of LV pacing on myocardial function, and using the global longitudinal strength and also the peak strength dispersion. So the LV strength was obtained using a standard manner, using the standard 17 regional segments, and the LV strength were obtained from the basal, mid, and apical segments of the LV free wall as well as the ventricular septum. All these strength analyses were performed using an inbuilt software, an average of 3 cardiac cycles. All echocardiograms were performed by the same echocardiographer and evaluated by 2 independent cardiologists. So we evaluated the echocardiographic parameters using the Wilcoxon sign during stats, pre and post implantation, and also studied the risk factors for worsening TL using the first penalized maximum likelihood logistic regression. We employed this methodology because of the small cohort size, and therefore we expected sparse data. And we also perform several sensitivity analysis by altering the outcome, altering the variable definitions, and also the method. So inter and intra observer variabilities was calculated using 10 random echocardiograms and by the two-way mixed intra-class correlation coefficients. And intra-observer for the primary endpoint. The intra-observer variability was 0.9, which was considered as excellent, and inter-observer variability was 0.8, which was considered as good. And other echocardiographic parameters was also studied for inter-observer variability, which was excellent or good. So this is a summary of the characteristics of this cohort. So the mean age of this cohort was 81.4 years, and half of them were male. Most of them has hypertension, and half of them had renal dysfunction. So about 40% of them had significant valvular disease, which was defined as any stenosis or at least moderate regurgitation. And tricuspid annuloplasty was performed in 8 patients. So atrial fibrillation was frequent in this group, which was 71.9%. And in most of the procedure, we successfully completed with 1 deployment. But in 4 procedures, we required 2 deployments, and 3 required 2 deployments. And this septal position was achievable in 85.9% of the cases. So this slide summarizes the echocardiographic parameters. So as shown here, the baseline echocardiography revealed none or mild, moderate, and severe TR in 69%, 28%, and 3% patients respectively. After a median follow-up of 14.7 months, none or mild, moderate, and severe TR were detected in 61%, 36%, and 3% patients respectively. When individual data is evaluated, up to 12, that is 19% of the patients has worsened TR after 1 year. This included 2 who had changed from none to mild TR, 9 who had changed from mild to moderate TR, and 1 who had changed from moderate to severe TR. There was also a borderline increase in RVV impairment assessed by tricuspid annular plane systolic excursion. Of note, the mean distance between the proximal end of the leadless pacemaker and the tricuspid annulus was 29.3 millimeter. In a primary multivariate analysis, we found that only distance between the leadless pacemaker and the tricuspid annulus was an independent risk factor for worse TR. The odds ratio was 0.87 and the p-value was 0.03. This corresponded to 50% increases in odds for worse TR, with each 1 mm decrease in the distance between the leadless pacemaker and the tricuspid valve annulus. To confirm our findings, we also performed some sensitivity analysis, which shows that distance between the pacemaker and the pacemaker and the tricuspid annulus remained to be a significant independent predictor of worse TR by altering the outcome using only including only patients who end up with moderate TR, and also altering the variable by using LVEF as a continuous parameter. The first sensitivity analysis, we only include parameters that achieves a p-value of less than 0.1 in univariate analysis in the subsequent multivariate analysis. And this also confirmed that the distance between the pacemaker and the TA was a significant predictor of worsened tricuspid regurgitation. And the odds ratio in all these 3 sensitivity analysis was comparable with the obtained from the primary analysis. So how does leadless pacemaker acceptance lead towards TR? So when we look back at this the table, first, during pacemaker insertion, there is still a chance of valvular leaflet perforation and laceration, as well as entrapment of the chordae tendinate. Although in prior in vivo and in vitro study did not demonstrate TR damage during the procedure, it is still possible. So how about ventricular pacing? So during ventricular pacing, we still can induce left ventricular dyssynchrony. Whether this is a significant cause of TR remains to be debated, but there are limited evidence supporting this possibility. However, for pacemaker retainment, it can also be one of the very important factors that lead to the worst TR. First, the pacemaker may still interfere with valvular lead coaptation, depending on the site of implantation. And the tie of the device may still lead to entanglement with the chordae tendinate. Obviously, fibrosis, encapsulation, endocarditis, and thrombosis are less common in this group, but they are still possible. So when implant, this is a possible mechanism of TR that we propose. So when we implant a transvenous lead, we usually focus on positioning the tip of the lead at the appropriate position. However, during the implantation of the leadless pacemaker, the story is a little bit different. Let's look at the diagram on the left. Implantations of the leadless pacemaker is performed using a very bulky device. So, and also we need to perform a gooseneck maneuver during the procedure. And sometimes this can lead to a little bit of pushing of the septum slightly. So as shown in the figure on the top, if the pacemaker is positioned with the tip just lying in the mid-septum, the final position may actually be displaced a little bit to the proximal area. After the catheter shift is withdrawn. This increases its chance for the leadless pacemaker to entangle the septal chordae, which are either attached to the small papillary muscles or directly to the septum. And second, the body of the leadless pacemaker has a diameter of 6.7 millimeter, which is 2.5 times the size of an ICT lead. If you leave it at the more proximal part of the septum, the lead body may interfere with the valvular leaflets as well as the chordae. So in the ultrasound shown here, you can see that actually the tip of the leadless, the proximal end of the leadless pacemaker is fairly close to the valvular leaflets. And there are lots of interactions between the leadless pacemaker and the chordae of the tricuspid valvular leaflet, which may actually be one of the cause of worsened TR. So finally, once the pacemaker is deployed, repositioning is not usually convenient as that's for a transvenous lead. So for most of the operator, as long as the sensing and pacing parameters are normal, they would take the position and won't risk retracting the pacemaker again and repositioning the pacemaker in a more the distal position. This may also contribute to an unexpectedly high rate of worst TR associated with leadless pacemaker in some of the case series. So paying attention to optimize the distance between the proximal end of the leadless pacemaker and the tricuspid annulus potentially reduce the risk of these complications. As you can see on this diagram on the upper right, if we just position, accept the positions here, although the tip of the leadless pacemaker is still in the mid-septum, but the distance between the proximal end and the tricuspid annulus would be quite short. However, if we further manipulate this to a little bit more distal position, then it's obvious that significantly increases the distance between the proximal end of the leadless pacemaker and the tricuspid annulus. So there are several limitations to this study. So this is a single center study and would be significantly affected by the performance of our operator. And we only include micro. And the echocardiogram was not performed immediately after device implantation in this study. And therefore, we are not for sure whether some of this can be caused by, as I said before, lacerations of the valve or perforation by the device, by the catheter. And also, strain analysis was only performed in the post-implantation echocardiogram, and therefore, whether a change in the strain may also be related to the worsened TL is not known. So to summarize, TL worsens in about 19% of the patients with septal leadless pacing, and close proximity of the leadless pacemaker to tricuspid annulus predicts worse TL. Careful positioning of the device away from the tricuspid annulus or using a shorter device may prevent worsening of TL following septal leadless pacing. So
Great.
Thank you very much.
Thank you so much. So let me remind our viewers that it's not the chat function, but Q&A. So if you have any questions, please post them in Q&A.
Well, Dr. Hai, thank you for a very good presentation. That was some excellent work, and we congratulate you for that amazing publication. So one of the questions that I had, while we're waiting for Q&As to come in, and we'll talk a little bit more about this as we go to the panel discussion, was we saw that a majority of the patients in your study were actually septal implants, which is phenomenal. And you also analyzed the number of deployments. Did you notice any interaction or impact of the number of deployments or the number of times you had to cross the tricuspid valve to actually deploy the leadless pacemaker on the worsening of the tricuspid valve function?
So a number of deployment was not the significant predictor in our study. And so we typically do not cross the tricuspid valve for multiple times unless we have to, the site is not okay and we have to retract the pacemaker. So I don't, so that's why I don't think passing through the tricuspid valve would also would be a predictor as well. The only problem here is I didn't really analyze the time, spent in the procedure, and the primary outcome, because this is affected by a lot of factors. So a person to manipulate very carefully and do the procedure slowly, it may not be a very bad thing. So, but in some of the patients, some of the operators, it may be because they, manipulate a lot inside the ventricle. So for this one, it is very difficult to quantify.
Do you think that the number of deployments being so low in your study population, as you can see, there were just a handful of cases where the number of deployments was more than one, right, may have had an impact on that, on the outcome in this particular case, it not being significant? Just a thought. Yeah,
possibly. But I only included patients who had septal implant that performed successfully. So there are still about 10% of the patients that were not included in this cohort because they ultimately has the apical implant. So the result may be a little bit different in this population.
Got it. All right, I think in the interest of time, we'll move on to our next presenter. Our next presenter is Dr. Jeffrey Arkles. He is going to be presenting his editorial that was titled Leadless Pacemakers in the Tricuspid Valve. Can you believe it? Can this be true? This was in response to the article, The Impact of Leadless Pacemaker Therapy on Cardiac and AV Valve Function Through 12 Months of Follow-Up by Bruskins et al. In Circulation. Before we get him to present his study, I just want to give a little background. So Dr. Arkles, who I've known for a while now as well on a personal level, is a native of Philadelphia. He's currently an assistant professor at the Hospital of University of Pennsylvania. He attended the Jefferson Medical School and the University of Pennsylvania for his cardiology and electrophysiology training. He has served as a faculty at the University of Pennsylvania since 2017, and his clinical expertise is in ventricular tachycardia ablation and lead extractions. He has active clinical and translational research grants focused on non-invasive radiotherapy for treatment of cardiac arrhythmias and co-directs the Penn Translation EP laboratory. He's also joined by the senior author on this paper and his mentor, who really needs no introduction, and this is Dr. Andy Epstein. His bio is extensive, so I'm gonna try to cut it short if that's okay with your permission. Dr. Epstein is a professor of medicine in the cardiology division at the University of Pennsylvania and the chief of the cardiology section at the Pennsylvania VA Medical Center. He graduated from the Amherst College in 1973 and the University of Rochester School of Medicine in 1977. He did his internship residency at the WashU Barnes Hospital, and he then went to University of Alabama, where he's completed his fellowship in cardiovascular medicine and was on faculty in the year 1982. He's a fellow of the American College of Cardiology, the Council on the Clinical Cardiology of American Heart Association, and the Heart Rhythm Society. He served as the chairman of the American Heart Association Committee for Sudden Cardiac Death. He's also served as the chair of the ACC-AHA-HRS Guideline Committee for implantation of cardiac devices, including pacemakers and antiarrhythmic therapy. He was elected to the Association of University Cardiologists. His teaching awards at the University of Alabama at Birmingham include a 10 Best Teachers Award from the Department of Medicine in 1998 and 2008. His research interests lie in the management of atrial and ventricular arrhythmias. He's been involved in numerous national and NIH-funded trials, such as the CAST, the AVID study, the AFFIRM trial, and the DAVID trial. He's authored over 400 papers, abstracts, book chapters, and served on the editorial board on top-tier journals across the country and internationally. Welcome, Dr. Epstein. We look forward to your participation in the panel discussion following Jeff's presentation. Jeff, on to you.
Well, thanks so much. And Parikshit, it's great to see you again. And congratulations on all your success. I was going to share this presentation with you. And Dr. Hai's presentation was superb. And I hope this isn't too redundant. So as she really very eloquently described a lot of the points that I was going to go over. Here. So just a quick overview. So briefly, especially after Dr. Hai's wonderful presentation, we'll just talk a little bit about the tricuspid valve anatomy and mechanisms of tricuspid regurgitation. And I was going to speak a little bit about just understanding the challenges in grading tricuspid regurgitation and why studies such as Dr. Hai's are so important in understanding how we evaluate and manage tricuspid regurgitation, especially as it's associated with transvenous or leadless pacemaker leads. The study that we're reviewing specifically about leadless pacemakers and tricuspid regurgitation and some conclusions. So I think this slide was already presented, but I think some of the salient points about the tricuspid valve as mentioned were that this is the largest valve in the heart, and it's built in with a lot of redundancy, and it's built in with a lot of heterogeneity. And we see in slide A, the large valve with the 3 leaflets, anterior septal and posterior leaflet, rising from the coronary sinus. And what we see is a smooth transition on the atrial side of the leaflet in panel C. And then the fibrous ventricular portion of the leaflet in panel B. And I think it's very important to note that there's a significant amount of heterogeneity in the leaflet anatomy. And as mentioned by Dr. Hai, that there can be a variable number of tricuspid leaflets, often referred to as accessory leaflets, with some people having as few as 2 leaflets and some people having as many as 7 leaflets. And I think one of the things that was challenging for me when I was trying to understand the subject is that the tricuspid valve is not the mitral valve, although there are a lot of similarities. The morphology, the redundancy, the structural function of the chordae and papillary muscles are much different. And I think, again, this leads to some of the challenges in understanding tricuspid valve incompetence. And I think, as many points have been made about the variability of the anatomy, I think one of the most preserved anatomical features are the septal insertions of the leaflet. And as mentioned, I think this was actually the same slide from the same review. You can see here that some of these chordae arise directly from the septal myocardium, while others arise from small papillary muscles. And most patients have both as well. But these septal insertions of the chordae are one of the more preserved features across most patients. And so this particular area, as you see the smooth infundibulum as it comes up into the pulmonic valve, and then this area where the chordal insertions of the septal leaflet occur, this is an important area. And I think, as mentioned, when we're positioning our leadless pacemakers or transvenous leads, it's important to consider these factors. And it can't be understated how subject to loading conditions and to left ventricular function, tricuspid valve regurgitation is sensitive. So primary tricuspid regurgitation, referring to an alteration of the valve leaflet or malcoaptation of the leaflets, is a very different form of regurgitation with very different treatments than secondary tricuspid regurgitation. And the understanding of functional tricuspid regurgitation, this was an excellent review in JACC Cardiology, or JACC from 2015, and sort of discussing the features that are associated with functional tricuspid regurgitation and leaflet coaptation, provided me with some excellent insights into this. Another important consideration is the effect that atrial fibrillation has in grading tricuspid regurgitation and the sensitivity of RV function to atrial arrhythmias, especially in the setting of pulmonary hypertension. And I think just to give a little bit of the introduction for an audience that probably doesn't need it, we put a lot of leads across the tricuspid valves, and this is a surgical view of 2 leads across the tricuspid valve. This is a Swan-Ganz catheter, and you can see this ICD lead has almost left an imprint on the septal leaflet of the tricuspid valve. This is, as was mentioned, a major source of morbidity and mortality for our patients, and it's something that we do and should care a lot about as electrophysiologists. This was from an excellent publication by mentor Dr. Epstein here, just showing various forms of tricuspid valve lead interaction. And I think the one in panel E is especially interesting, where you see this fibrous cast of a removed pacemaker lead against a tricuspid valve, which has altered the mobility of the leaflet of the tricuspid valve here. And as somebody who does laser lead extraction, I think extracting leads, especially ICD leads, is very, very important to understand that we can do a lot of damage in taking these leads out, potentially more so than putting them in. And this is a really striking example of an avulsed tricuspid valve with small attached papillary muscles after a lead extraction here. But again, I just want to remark on how challenging it is to assess lead-associated tricuspid regurgitation. There have been many studies, and I just chose this one because I thought it was very useful. And this was at a Mayo Clinic in heart rhythm in 2018, where they randomized patients to apical, septal, and coronary sinus lead positions and performed echocardiography in a prospective fashion, both before and at 1 year after implant. And were actually unable to show any difference in tricuspid regurgitation amongst these different positions. And I think this in no way means that leads aren't associated with tricuspid regurgitation, but just to mean it's challenging to assess it because of all the challenges mentioned in differentiating primary versus secondary or functional tricuspid regurgitation and its quantification. And so I think this was a really, really exciting study, which was already mentioned by Dr. Hai, but when Dr. Epstein mentioned this study to me, I really couldn't believe it. This was the aforementioned Burskins et al. Study showing the impact of leadless pacemaker therapy on cardiac and AV valve function through 12 months of follow-up. And as mentioned, this was a single center study, prospectively acquired echocardiography using a specialized protocol to answer this question of patients receiving leadless pacemakers, micra and nanostem in an approximately equal fashion. And I think what was very clever about this study is that they had an age and gender matched cohort of dual chamber pacemaker patients as a comparison, because TR often worsens with a multitude of factors. I think having a control group was very important. And comparison of echocardiographic endpoints at implantation and at 12 months were made for the primary analysis. The primary findings of the study were very interesting. The leadless pacemaker group had worsening of tricuspid regurgitation by 1 grade or more in 23 or 43% of patients. And this was equivalent or potentially even greater than the dual chamber pacemaker group. And it was hard to believe that this was possible at the time. And when you looked at the breakdown of this, TR increased in 43%, reduced TR in some, and equal TR in roughly half of patients. MR also increased in 38% of patients. However, the TR increase did not correlate with those patients who had increases in mitral regurgitation, and it did not correlate with patients who had a reduction in LV systolic function as well. MR and reduction in LV systolic function were associated with the amount of pacing from these leadless or lead transvenous lead pacemakers. And as very, very well described by Dr. Hai, there was a very provocative association with less tricuspid regurgitation with increased distance from the base of the tricuspid valve. And I think this really brings home a lot of the points that were mentioned. And on the left here is a looping echocardiogram. You can see a leadless pacemaker. You can see the base of the leadless pacemaker. And if you use a little bit of imagination, you can almost imagine those chordae or the tricuspid valve apparatus interacting with the base of that. And so compared with the apical position, the RV septal position, the leadless pacemaker had a 5-fold odds ratio with a significant p-value. This is just my PowerPoint special, but just showing how the tricuspid valve apparatus can potentially interact with the septal position, whereas the apical position, or as Dr. Hai mentioned, the increase in the distance between the tricuspid valve plane and the base of the leadless pacemaker could potentially affect these interactions. And as mentioned before, the mechanism here didn't appear to be traumatic. These were changes at 12 months, not at implant, that we're seeing in the study. And so I think, as already mentioned, there's certainly the potential for tricuspid valve damage and implant. And as mentioned, this seems relatively unlikely, based on the physical characteristics and preclinical and clinical data. This doesn't seem to be that the leadless pacemaker sheath or something else is acutely engaging with the tricuspid valve apparatus and rupturing chordae. However, it does seem that the mechanical implant itself has some interaction with the tricuspid valve. Secondary measures, at least in this study, were well controlled for, and pacing-induced dysynchrony, the amount of pacing didn't correlate with tricuspid regurgitation. Similarly, mitral regurgitation and worsening of biventricular function didn't correlate. So the potential takeaway from this study is that the distance and the mechanical interaction of the leadless pacemaker was the potentially the most important impact. So just briefly, the conclusions are that leadless pacemakers are associated with similar changes in tricuspid and RV function compared with transvenous leads. The implant position of leadless pacemakers is associated with a degree of tricuspid valve dysfunction. Leadless pacemakers and transvenous pacemakers have similar risks of RV, LV, tricuspid valve, and mitral valve dysfunction. The optimal site for leadless pacemaker implantation may remain to be determined, as well as the optimal design. And the length of these devices may be reconsidered based on the Burskin's findings or Dr. Hai's findings from her study as well. And Dr. Epstein, if you have anything to add, I'd love that, or we can wait for questions.
Thank you, Dr. Arkles. That was wonderful. And I love some of the images that really help to highlight the challenges of this research here and the association between the valve and the placement. There is a question in Q&A, which is there any relationship, and this might be best for Dr. Hai also to jump in on, was there any relationship between amount of pacing and tricuspid regurgitation?
So it's one of the parameters included in my analysis, and it was not found to be a significant predictor. But having said that, most of the patients has quite significant, amount of pacing. So they're ranging from 50 to 80%. So if we don't have a group of patients with very low amount of pacing yet.
Okay, great.
Jeff, for you, so based on the data that you presented or the editorial that you guys wrote on this beautiful study, it seems as though the nanostem device, which is longer than the micro device, is more likely to interfere with the tricuspid valve apparatus and thereby impact tricuspid valve regurgitation. So would we then conclude that it might make more sense to implant that device more apically than the micro device? What are your thoughts on that?
I think that's a really smart question. And as a non-European who's never implanted a nanostem, I have to use my imagination a little bit. And when I've talked with people who have implanted it, is that there has been a significant risk, or at least concern, for effusion in those patients, and so that was something that was sort of mentioned in the study, is that they did prefer the septal positions for the nanostem in particular, whereas the micra they were more open to the apical positions. So I think that is really I'd be very interested to know if any of these companies, when they were designing these devices, had this thought in mind. And I wonder if the shape or the implant suggestions might differ based on these findings.
I was going to say, I'm not sure that the difference in length between micra and nanostem really makes a difference. It might be that the threshold is already crossed by the length of micra, and any increase in length isn't going to make things worse. Might be more reasonable to go in the opposite direction, to make a flatter pancake to go up against the septum than think about the length. Along those lines, to me, it's very paradoxical when you think about it. There's such a literature, which is mixed, that septal pacing causes less LV dysfunction than apical pacing. Now here we're saying it might be better to apical pace. I think that's a disconnect. And then I think one of the fascinating things in the Berskin's article is that for people who had less than 10% of pacing, they still had 50% increase in TR. And what that tells me that pacing isn't the problem here, it's something mechanical with the device. It's totally unexpected, and I don't think the companies could have predicted that. It's something that doesn't cross the tricuspid valve would cause TR, but it does.
So what is the next step for research? Do we have all the information we need, or what would you do to design the next trial? I think one of the challenging things is really finding the right control group, right? Because patients that get a micra are a specialized population. They're older, many of them are in persistent AFib. So do you think that we need more studies to define this, or do we sort of have what we need to know to start, encouraging changes in the device shape or implanting more apically?
I guess we'll open it up to the panel, so all of you guys can comment one at a time.
I would love to say that we have everything, but there's still such a debate on transvenous leads and what matters and what doesn't matter. And my own partners still have a lot of disagreements about how to handle those issues. And I think this will become more and more relevant as we enter the age of tricuspid valve repair. We have the ability to treat these things. So my guess is that we will be much more conscious in 5 to 10 years of impinging on the tricuspid valve that we are now. I think this will be something that our colleagues in echo and heart failure and interventional cardiology will emphasize more and more because it's real. There's a real impact on mortality and morbidity for our patients. So I think certainly more is needed, and I think there will be further effort to avoid interaction with the tricuspid valve apparatus, and I think we need to move there. Certainly more research is needed, but I think this is enough to make me change some practice at this point.
Yeah, I wonder if with advances in more imaging, as you're pointing out, three-dimensional echocardiography, for example, or MRIs after these leadless pacemakers have implanted themselves well, making an MRI, I guess, more feasible to do, and actually see what structures the device is implanted into and what structures may be being impinged upon as the leadless pacemaker wags about. Maybe that would give us a little bit more idea, though it is not as quantitative as I might hope it to be. It may be qualitative enough in order to give us more ideas later.
So in fact, I performed just three-dimensional echo for all of them. The problem, I didn't include that in my results because it's really very difficult to interpret. So we know that there are lots of variations, especially because there are lots of variations in terms of anatomy, and the image are not as good as what we want. And as you said, maybe MRI works better. But having said that, for example, in series, only about 19% of them has TR. So if you do MRI for them, the 100 patients, and then you may not still, this is pretty qualitative, and you may not still get the answer. And from my point of view about implantation, I still like septum. We still implant the device at septum. Let's just pay a little bit more attention. So in fact, when I observe what my fellows are doing, so I feel like, we try not to retract the leadless pacemaker. So because of that, the practice is whenever we deploy device and its pacing parameters are perfect, then we will leave it there. But in fact, it actually shows us maybe we have to be more cautious before we really deploy the pacemaker. So instead of anywhere we get, but a little bit more distal than usual may be needed, because in the usual pacing we only concerned about the lead tip, the position of the lead tip, because our intention of septal pacing is to provide a better, more physiological pacing. But for leadless pacemaker, what we concern is also the lead body. We don't want the lead body to be, around the apparatus. So maybe because of that, we need to be more cautious, not to just focus on the tip, but push it a bit, more in to make sure even the body is in the mid-septum.
Here's a wacky idea. What about a flat AV leadless pacemaker that you screw through the high septum into the left bundle branch area?
I knew you'd go there. I knew you'd go there.
Perfect.
We should get a patent for us on this call.
No, but Dr. Epstein, just to add more to that, do you actually think that we have all the data, or would you want to play devil's advocate and say we actually need more data to confirm some of what we're saying?
As you said there in the introduction, I'm a clinical trials kind of guy, and data and comparison are needed. There's nothing that improves outcomes like not having a control group. So the answer is yes, we need more. On the other hand, if length of the device is seemingly a problem, crossing the valve is a problem, if you could make something flat and to get into a physiological pacing area, it sort of makes sense that might work.
All right, one final question. I think we've sort of got a good feel for what these devices can do in terms of impacting the tricuspid valve. And I think, Jeff, this might be up your alley as well, but I'd like for everyone to comment. Where do we go from here? Like, if you deal with a patient that you see a year later and now you see has severe wide open TR, of course, we'll try to figure out if it is functional or if it is, impingement of the valve, but what is your next step? Do we actually try to take the micro device out? Do we call our surgeons in? Where do we go from here?
I don't know the answer to that, but I think it's fascinating. And I've taken out one micra, and as everybody probably knows, there extraction tools for micra are, there are really no extraction tools for micra. There's nothing to retract the splines. So you basically, can snare it and pull it out, but you're hoping those splines don't take anything with it. So there's no counter traction, there's nothing else. And it's so hard to say. It may be that, as we saw in some of those examples, there's a lot of fibrous tissue that comes with it, or the coating may prevent that from becoming an issue. I'm really fascinated to find out, and I think especially as we eventually get to dual chamber leadless pacemakers, the extraction tools will become more and more relevant, and it'll be very, very interesting to see where this goes. And I think, especially in our heart failure population, I think this is something that I'm personally seeing a lot more from our doctors asking that same question. It's like, hey, Jeff, this patient has a pacemaker and they have TR or an ICD, and it's just a really hard question to answer right now. Is that loading conditions? Is that their secondary, functional TR got worse? And it's a really challenging question that I think now that imaging specialists have really made leaps in defining this in 3D echo and other modalities, have really been very helpful in showing when this is primary TR and when extraction might make sense or potentially make things worse. But it's fascinating. I think we definitely need more work there.
Could I just bounce off the last two comments with one thought? You mentioned that the surgeons can get involved in this. There's at least one paper now that we wrote a letter to the editor about in the one of the interventional journals of transvenous implantation of a tricuspid valve, but jailing pacing leads. And they just sort of blew through this in the paper, and we have to be involved as electrophysiologists and say, this is not something that we subscribe to. You can't jail these leads, because when they get infected and they're like that, you've got a prosthetic tricuspid valve, that patient is cooked.
Well, I want to thank everyone for a great discussion. I think, Dr. Hai and all the commentary, when research challenges what we sort of take to be true and then turns out not to be true, that's just such a remarkable thing that research does for us, and then makes us try to understand why it wasn't how we expected. So what a great discussion, and thank you all for being here with us tonight. I also want to thank Dr. Wang for his leadership and Christina Sein, who helps us keep everything organized and on track.
Well, again, thank you all for joining. Again, thank you all and have a very good night.
Thank you.
Thank you all.